and try and bring it in-house. I need to give board assurance that we're still reporting to NHSE instead of in terms of feedback from our patients. So what we are doing at the moment, we are doing face-to-face with our patients rather than the texting that is for friends and family. We have benchmarked across our patch, and the other trusts are still using friends and family, but also considering going into in-house. We will launch the in-house in Q2. It has been delayed because of the Lorenzo issues that we have heard, but the feedback we're having from patients is really positive.
Great. Thank you for that update. So let's get the main part of the meeting underway, the patient story, an essential part of any of these meetings. Tabitha, do you want to introduce this month's patient story?
Thank you, Chair. So before I bring in Maddie to talk about transforming NICE guidelines, I just wanted to sort of say, I have acknowledged feedback in terms of what we've tried to do with our patient stories, Chair. Just for clarity for you, we've tried to balance patient stories, staff stories, and also quality improvement initiatives. So the story today is around one of our quality improvement initiatives. It's also from the back of where we need to continuously improve, listen, and engage our patients. So we've tried to balance that. So moving forward, if board is requiring just patient stories, we are prepared to do that. Thank you.
Excellent.
So over to Maddie and Anne.
Good morning, everyone. It's my first time here, so I'm a bit nervous. Thank you for giving us the chance to talk about our what started as a little project that ended up as a national project. This presentation is about transforming the NICE guidance into practice, but I'm going to focus on the element of enhancing the patient experience. It all started as a small project within the Northwest NICE Forum. I've been the chair of that forum for a couple of years now, and we acknowledged that across the Northwest region, we had an incomplete system where this trust will implement the guidance this way, the other trust will do it the other way without having something to refer to. Unfortunately, NICE doesn't give us that element of this is the guidance, this is how you implement it. It's more of this is the guidance. So we had to come together and put a step-by-step process. How do you approach the governance part? How do you involve the patient into that, as in this is what we're going to offer? How do you feel with all these changes? How do you measure your compliance in terms of your KPIs? So we started as eight-member trust. We end up by signing that, before signing that document, with 34 NHS trusts, and we went across the region. We had from England, from Scotland, from Wales. Once this project started to develop, with putting it all in one piece of paper, it's been acknowledged by NICE as in, yes, this is what we're expecting you to do. So it's been recognized of how the adaptability of it is good, and the scalability in terms of the region. So it's been proposed as one of 100 projects for the Ruth Young Northwest Research Award, and we've been a finalist in that. Additionally, I think that the most important part from an office perspective is that it gave us that chance to be recognized as a trust of the work that we're doing. NICE doesn't have on their website anything like this, and they actually decided to host this document and to be referred by other trusts, and that is very, very important. But probably you're wondering, right, okay, so what's the patient experience part here? This is our day-to-day job. When we're talking about guidance, and when we're talking about, next slide, please, about guidance, you have different ones. You'll have guidance that will tell you this is how you do the procedure XYZ for the illness. But we also have guidance that will refer on how do we approach elements of how we make the patient feel. One of them, and a very important piece of guidance that we implemented with big efforts, and the project is still undergoing, it's NG 197. NG starts from NICE guidelines, and that's the number, shared decision making. Shared decision making guidance, it involves the patient and also has the element of us having that discussion and making it in a way that the patient will understand what are the benefits of having that procedure, that medicine, what are the risks, what are the alternatives, and what will happen if we don't do nothing with them. But by having this process, we make them feel that they are involved in their care, and there are numerous research out there that shows that any patient that the more involved they are in their care, they are going to recover faster if they have that willingness of being part of that care. So once we start putting this shared decision making into practice, we focus on two elements, our staff and our patients in terms of education. So we started with our staff and we asked them, what tools do you use? Do you know anything about this? This is how we would like to do it. But we also approach the patients as well. Say, you should expect to be involved. If you're not, can you prompt the clinician in front of you? Ask them, what are my benefits? What are my alternatives? And by doing both of the education, we are expecting to get that feedback back. It's very hard to put a number next to it. So it's very hard at the moment to quantify that since the project is still going. But we started to get feeds through our patient experience and the family and friend test and all of that, where it says, like you see on the screen, everyone is kind, keep you informed. We want that communication informed. I've been made to feel part of that decision. Next slide, please. As I said, it's quite hard to put a figure on this. It's like asking, yes, we should treat everybody with dignity and respect, but can we tell a number next to it? No, we want 100%. It's the same with shared decision making. We want everybody to have that. We do have one question into our friends and family test that we can actually measure and see. So for this, because this is not part of my work and I'm not going to take credit for, I'm going to ask Annette to present these numbers.
Okay, thank you. So here we have some patient feedback figures, which come from our temporary manual FFT survey system. So this is these figures come from between the 1st of March and the 31st of May, whereby we asked 1,094 patients, were you involved as much as you wanted to be in decisions about your care and treatment? You'll see from the pie chart that we've got 71.94% of our patients said yes, 4.2% of our patients said no, 5.39% of our patients said maybe, and 18.47% didn't actually answer the question. So the bar chart shows the 5 areas in which we have to report friends and family test submissions to NHS England. So that's community, ED, maternity, outpatients and inpatients. So next slide, please. So we have just some more figures here. So since we've been doing the temporary manual FFT system since the 1st of March, we've added these 2 questions to our friends and family test survey. So again, same time frame, same amount of patients. We asked them if they our patients were treated with dignity, kindness and compassion by our colleagues. Again, you can see from the pie chart, 80.53% of our patients said yes, 1.37% of our patients said no, and 3.11% said maybe, and 14.9% didn't answer the question. So I can feedback on behalf of the patient experience team. We are all participating in face-to-face communication with our patients on a weekly basis, and the feedback that we are receiving, you know, is quite good feedback, very good feedback overall. And we feel it's lovely to chat to our patients, and if we're finding any common themes and trends, we're able to sort of do something about it then, and then report back to who we need to, rather than wait another month to get the feedback from our supplier. So I'm going to hand back to Maddie. Next slide, please.
As we come to the end of this small presentation, I just want to leave you with something simple. Implementing NICE guidance, implementing processes, and doing all the audits. The purpose behind it is not for us tick boxes. And I think that's the most important thing. It's about the people. And two most important phrases when I come to work every day. It's one, it's about the person that walks through our door. And I walk through those doors as a patient in this hospital and other hospitals, and I know that they have anxiety. They will, it's about the family that will come with their loved ones, and they give us in our care their loved ones. So for them to come in our care, and for them to, the way that we make them feel that they are safe, that they are respected, that we know what we're doing because we're asking the right question and we involve them in our decision. This is all about our jobs and everything that we do on a daily basis. Very, very important on the same page. It's about our colleagues implementing all of the NICE guidance and all of the evidence-based research guidance. It's about our colleagues that they need to be made feel confident and competent and supported in their job. To provide the safe care and to provide the best care that they can for the patients, that they care every single day for the service users and for their families. As I said, when we follow evidence-based guidelines, it's about improving the outcomes, and we are restoring that dignity and that safe care, because at the end of the day, this is what patient-centered care means, to make it about the patients. And everything that we've done and I presented here, yes, it is about the back office and all the paperwork that we do, but it is about the patient and the patient-centered care.
Thank you.
Brilliant. Any questions?
Thank you, Maddie, Annette, thank you very much for bringing the presentation to board this morning. It's a really good example of all of the teams that are involved in direct patient care and the improvements that we need to make. So I've just got a quick question. So it's really good to see lots of the good and positive feedback. But for the areas on both questions where patients answered, no, I didn't feel like I was engaged enough in my decision making, or no, I don't felt I was treated with compassion. Do we pick up any themes or issues in the negative responses that might lead to further improvement?
No, I'd have to look further into that, Aaron. Yeah, for departments maybe. Yeah.
I think that's the richness of this kind of approach, which is it's really good to get the positive. And I know we have a tendency to have a negative or a deficit-based view of information we see. But I do think in those areas, that's where you'll find potentially the next phase of improvement or the next phase of the resort. I'd encourage you to be curious about the no responses and to explore what might sit underneath some of that might make further improvements on.
May I add here that I like to bring things when they're done, but I'll give you a bit of a hint of what we're doing behind. When we started the shared decision making, in order to have a baseline, we had to measure something. So we've done a survey of patients in two specific areas, and the service for our staff in those same two specific areas. So when we picked up, one of the question is, have the doctor, the clinician giving you during the consultation all the options? When they said no, we took that feedback and give it straight there and then in a very positive and encouraging way. So we do that feeding back to our teams. So we've done the graphs, we didn't point any fingers, we said, this is, can we look at this? So we're doing that feedback straight back and for the patients as well. Thank you.
Great. I'm going to bring in Carrie online and then go to Sarah in the room. Carrie.
Thank you. It's great to see focus on patient feedback, always really welcomed. So thank you for presenting. My questions really are just on, I noticed that we've obviously got a high percentage of feedback for inpatients, but community and maternity are particularly low. So I just wondered if we had any plans to address that and try and increase the amount of feedback we get in those areas.
Okay, with regards to community, our team aren't actively going out face to face getting feedback, except for Queen Vic, I think at Queen Vic Hospital. So I met with Kim Crabtree and some of her team, and asked them to cascade. We have like business cards and posters up, out and about in the community, trying to engage with patients to scan the QR code and give feedback. So community is low, but it was always a lot lower even when we used healthcare comms with the text messaging. Hopefully once we've gone in-house, that will improve once the text messaging service takes over again. So hopefully that will improve. With regards to maternity, we do visit RLI and FGH on a monthly basis, and we do speak to our patients. Again, the posters are up on the wards, delivery suites, and we have double-sided business cards. So we can only reach, we are a small team, and we can only reach so far with our other roles. Obviously, we have asked for the assistance of the maternity team to help us try to get more friends and family test feedback.
Tabitha, did you want to come in response to Carrie's
Yeah,
question?
yeah, definitely, Chair. Thank you. So the new in-house system is scheduled to go live Q2. So it will support trust-wide community maternity inpatients and once it goes live. So I just wanted to.
Great.
Can I just ask one follow-up question? I suppose it's just considering the way that we get feedback, which has been touched upon. I'm just thinking community tends to be a lot of frail elderly people that perhaps aren't great with digital technology. So I suppose it's just if we can look at the means that we get feedback.
Yeah, I'm sure we can take that on away. Sarah?
Thank you. It was partly responding to Aaron actually, but just to confirm, so in Quality Assurance Committee, we receive the quarterly patient experience report, and we also receive the quarterly complaints report. And one of the things that Quality Assurance Committee has also asked for is, as part of that reporting, can we actually also see more on the themes that are coming out in terms of, particularly in terms of complaints and issues, and then a sense of the actions that are being taken. So that's something we've already requested from the Quality Assurance Committee.
Great. And then Nicola.
Thank you, Chair. Apologies to everyone for not being on video. In relation to the matter being raised around digital inclusion more widely in the community, what are our partners doing across the Integrated Care Partnership to help our patients in the community have access to support? I'm thinking link workers, social prescribing, that may be able to also then help us with that reach.
Ali?
Nicola, I picked this up as a discussion item in the system-wide digital steering group this last week. So I think we will start to see more on this agenda because it's key to enabling some of the transformation activities that we all want to progress. So I'll keep you informed offline if that's helpful.
That would be great. I've seen some really good practice of this elsewhere, and I know that it can be very effective. They're very good at this in Lincolnshire, if that's a helpful place for you to reach out for learning, Ali.
Thank you.
Are there any further points on this item? If not, Maddie, Annette, can I thank you for coming today? Can I thank you for everything you do for the Trust? Keep up the outstanding work.
Thank you.
Turning to item 25 on the agenda, my report. The only thing I want to highlight in that report is my huge thanks and the board's huge thanks to Tony, who of course stepped up and acted as interim chair.
Thank you, Chair.
Between myself and my predecessor. But apart from that, I'd take it as read. Any questions? If not, We'll move on to the Chief Exec's report. Aaron.
Yeah, thank you, Chair. So quite a bit in my report this month because there's quite a lot going on, particularly in that national and regional piece, which I'll spend just a few minutes pulling out some key details, in particular attaching to either onward work with the boards or a session that we'll be looking at in September. So we're awaiting the 10-year plan. We've had notification that this will be released tomorrow. So we'll make sure through our engagement channels that we share the documentation and any key messages as soon as we see them. We're expecting to see more detail on the 3 shifts, from a focus on prevention, a focus on digital, and a focus on community and primary care expansion. And we're also expecting planning guidance for next year to come out as a very rapid follow, so maybe later in July. That's likely to have a longer time period than we're used to having with planning guidance. It's normally annual in the NHS, or has been for a long time. There's mixed views as to what period of planning that the guidance might be giving us this time, but it's likely to be longer than a year. So for both of those pieces of work, what I've agreed with the chair is we'll be setting up a session in September, just to give us a bit of time with the executive team and others to consider what the plan is saying, what the impact is for us. So we'll do a strategic review in September just to check back as to whether this year's plans are engaging with the objectives we'd expect to see still, and to have an early insight into what our ambitions are for next year and the year beyond on the back of that. So exciting to see the detail that's going to come out of that in Thursday. It feels like it's been trailed for a long time. Second update, you'll have seen in the press, and we've circulated to board colleagues before, the 23rd of June, that the Secretary of State announced a rapid independent investigation into maternity and neonatal services across the NHS. That's been on the back of significant quality and safety failings in those services. And I think we'd all recognise that maternity and neonatal services are not where they need to be across the country. There are too many examples with too much evidence to say that actually the quality and safety culture, the quality and safety environment, the focus on listening to users of the service is not producing the improvements in quality of care that we would want to see. The Secretary of State highlighted there are going to be 10 organisations that have a rapid investigation approach and rapid improvement focus. That is not going to be us, as you'd expect me to say, given where we are with our service improvements in this area. That said, we will want to engage fully in the national investigation and share our learning from the maternity improvement work we've done, but also take on board any further learning, which I'm sure there will be across the country to adopt that. We have our National Maternity Support Programme visit later in July. That's intended to have a 2-day intensive review, similar to a CQC type inspection, and that's about assurance around our exit criteria for the programme. Again, I would expect us to participate in any national work alongside the exit from that programme, which is planned later this month. Latterly, on the kind of national, which dovetails into regional, we're also awaiting the final proposals for what we would call the blueprints, the changes to the operating models and the way of working with the Department of Health and Social Care in NHS England, what that means for NHS England regional teams and what it means for our integrated care systems. I know it's been a challenge for local teams in responding to the blueprint ask, which is around restructure and reducing operating costs. And that doesn't go unnoticed by our teams when we're interacting with colleagues in those structures, just to be supportive, kind, and in any way we can to make sure we can still deliver what's required of us over that period. We haven't got a set date yet for those blueprint pieces of work to finalise. There is a conversation about the autumn, and then there's definitely a date around having these completed by December. But as we get any further updates, particularly impact for us as an organisation, we'll feed that into the September workshop that we're planning. Regionally then, and with the ICB, there's obviously a reflection of those 3 key programmes nationally. But a couple of bits just to highlight. We've had some real success stories this month with some pieces of work, one of which I've led as the Learning Improvement Network Lead Chief Exec for the North West on urgent care. So we've been chosen as one of the national pilots for a focus on acute frailty and frail elderly. That's going to come with some resources and a national set of benchmarks and pathways that we'll deploy. This is the first time that we've agreed with the region that we will do this consistently across the 3 ICBs and all providers in the North West. Once we have more detail of the what, by, when and the impact we should expect to see, we'll bring that through board chair, just to make sure that we're clear on that. We were also successful in 2 applications from our ICB to be part of the Neighbourhood Pathfinder pilot projects. Again, this attaches to the 10-year plan, particularly the focus on that left shift out into community and primary care. And you will have seen the letters IHO feature quite a bit in some of the pre-messaging for the 10-year plan, integrated health organisations. Again, I'd want to come back with the board chair as to what do we think that means for the Bay? What does it mean on the back of the work we used to do around Bay Health and Care Partners? And does this pilot give us an opportunity to expand further into that area? So some really good news, I think, for this patch being supported nationally. I know Ali will want to say a bit more about some work that we're doing nationally on digital as well, which is we're getting support when it comes to digital items later on board agendas. We have had a number of conversations with the ICB to try and bring closer things like commissioning intentions, commissioning plans, contracting plans to sit alongside the 10-year plan release and one planning guidance, which is going to come in July. That means that through the summer, we're going to be engaging in cross-partner commissioning workshops. So we'll be able to bring much earlier to the board, what does that mean for our clinical strategy? How will that support things like demand management and consumption reduction, which we're looking for? So pleased to see some responses in the system on building early some of the ambitions around our clinical changes. From a trust perspective, I'm going to finish on a particular message, Chair, but we've had a really busy kind of first 2 months of the year, 3 months of the year. We took a lot of feedback last year on our approach to communications, engagement, visibility, and as an executive team, and pleased to see the chair and Susie attending some of these sessions, we wanted to go out and speak to stakeholders and our communities and our colleagues about our forthcoming changes this year. We've met with probably 600 to 700 people over this last couple of months, in person, on site or on Teams, to walk through kind of the scale of change, the types of change, particularly that digital innovation and clinical transformation programme that we're taking forward. It's been met with really positive feedback from the perspective of engagement and connection and listening and answering questions. We will still face challenge through this year in delivering those changes with the impact on colleagues' experience, which will need to be cognizant of, but really good, positive early feedback on that engagement approach. I will just say a thank you to the executive team in particular. It is very hard to do that session probably 15 to 20 times and still bring it to life with enthusiasm and connect with colleagues, but conscious for a lot of those occasions, it's the first time colleagues have heard it. So thank you for bearing with that. I know it was a challenge at times. We've had 2 significant announcements around capital investment, all down to how our teams have been delivering and leading over this past period. So we've secured about £2 million just over for urgent care capital investment, and that's on the back of being one of the trusts recognised as the most improved in some of the metrics that we have for urgent care, which is great. And just over £4 million capital awarded for things like infrastructure and managing risk, so air handling units and some of the infrastructure we've got around our kind of electric infrastructure. So not quite the shiny front of how CDC type investments we've had, or theatres, but critical nonetheless, and it's good to see that investment coming. I'm going to end, Chair, if I can, just by recognising it's Tabitha's last board. So Tabitha joined us, that's 2 years ago almost now, isn't it? Just over 2 years from Nottinghamshire. And Tabitha, I think, is leaving a fantastic legacy. So 2 years with us, been part of the leadership team for quality and safety improvement that's led to CQC conditions being lifted. We're right on the cusp now working with the maternity and midwifery leadership around MSSP exit. Absolutely pivotal in our work around the memorandum of understanding we've got with our local universities, particularly University of Cumbria. Huge impact in our NMAP leadership culture and the work that you do with our senior leadership teams with our nursing, midwifery and allied health professionals. So your impact, Tabitha, has been outstanding. I think your compassion and your focus on patients and development of your teams is exemplary. I think it's a fantastic example of what we would expect to see from any leader, and don't often see it all the time. So thank you for that. I know that you're retiring from the NHS but then Jersey's gain is the NHS's loss. So I'm very jealous of that next chapter in your life, you and your family. You'll leave with our love and best wishes, you know that, and we'll obviously embarrass you a little bit more before you leave us later in August. But I just wanted to put on record my thanks and the thanks of the board.
I couldn't have done it without your support and without Mike Thomas, the previous chair, and we welcome the new chair. And I couldn't have done it with my colleagues, all the executives and everybody in this room support. So thank you.
Thank you. That's the end of my.
Smashing. Any points of clarification or anything for the chief exec? If not, oh, sorry, Sarah.
Thank you. I just wanted to add to Aaron's comments, actually, just to pay tribute to Tabitha and the contribution to the trust. So as partly as chair of the Quality Assurance Committee, but also on behalf of the non-exec directors, and I guess Andrew, because you're new. I just wanted to say, Tabitha, it's been an absolute privilege to work with you, and you're absolutely that champion for quality and safety, and you receive all of our questions and assurance questions and things with, you know, with professionalism, and you note them and you take them on and you work with your team. And I think that progress we've seen across fundamentals of care, across safe staffing, across compassionate care, etc., has been huge. So from a quality and safety perspective, I think, you know, you'd be a hard act to follow, and we'll be really focused on trying to make sure we maintain that. So I also personally, and as the non-exec director, just want to say thank you as well.
Thank you for your support.
Well said, Sarah, and yeah, echo those views. Thank you. Okay, let's move on to item 27, the lead governor's report. Susie.
Yes, we have my report. I hope it's taken as read. But any questions? I'm open to any.
Great. Any questions for the lead governor? Oh, no. If not, nice and simple. We'll move on to the maternity update report. Tabitha.
Thank you, Chair. I need to breathe. So we received maternity reports for women advising and assuring board around how we are delivering and how we are having oversight of our maternity services. So there's quite a few papers in maternity, and Susan will take us through the escalations and the assurance that is required. Just to say, these papers have been through to QAC as well.
Great. Susan.
Good morning, everyone. I'll not linger on this because it's been discussed in detail at QAC. Just 4 highlights for this report. First of all, just to reiterate the MSSP assurance visit on 21st to 23rd of July. We are really looking forward to the team coming and us being able to showcase and demonstrate how far we've come in maternity. So we're quite excited about that. My second highlight is the self-assessment against the NHS maternity self-assessment tool. We're showing steady progress in that. We're now at 88% compliance, and that's up 10% from last year, which is good progress. And for the things that we are not yet compliant on, what we do is add those items to our maternity action plan. So that work continues. Just out of our maternity dashboard analysis, there are 4 areas that are in special cause for concern. Each of those areas have programmes of work against them, so for assurance and being monitored on a weekly basis for each of those. And lastly, the maternity and neonatal improvement plan progress continues. We've now completed 83 out of the 100 improvement actions on there. And they've been complete and verified by the Maternity and Neonatal Improvement Group, which has LM&S oversight. And just to reiterate that that is a dynamic working plan. So that plan never comes to an end because we continue to add to it to make sure that we have that continuous improvement running through the whole service. And that's it for me.
Thank you, Susie. Any points? Sorry, I'm ridiculous.
You go first. Go.
Thank you. So, from a Quality Assurance Committee perspective, we received an extensive suite of maternity reports at the last Quality Assurance Committee, as Susan's noted, and to confirm that we looked at all of these and obviously noted there's been significant progress actually. Just a couple of things that we noted is, we talked about this last time, but just to clarify, there is a deep dive going into around induction of labour, and that's going to come to Quality Assurance Committee. I think it's in October, isn't it, or August, because of sort of just timelines and the other work that needs to happen at the moment in maternity. But I think broadly to say that we did go through these reports in detail and you know, are assured by the progress that's being made anyway, which has been doing it.
Thank you, Sarah. Aaron. Sorry.
Thank you, Susan. Just on the 4 areas of special cause concern, and this might be covered in Sarah's update as Chair of Quality Committee, have we got a clear trajectory for each of those 4 areas aligned to the action plan as to when we think they'll come back into normal variation?
Yeah, yes, we have, Aaron. So with the term admissions to the nursery, we've already seen a downward trajectory with that, and we're concentrating on 2 particular areas which seem a bit stubborn, and that is babies' blood sugar levels and also babies' temperature levels. So there's specific bodies of work going on around that. It's actually moving very quickly towards common cause variations. So I would think in the next couple of months we'll be there with that, with this additional targeted work. For the induction of labour, actually the whole induction of labour forum is causing me concern at the moment, which is why we're doing a deep dive into all aspects of induction of labour, including service user perspectives, because I'm getting different feedback from you know, from the data, from consumer feedback as well. So that work will conclude and be reported on in October. The delays in induction of labour, I can't give you a trajectory on that, because actually we did a deep dive on the data, and actually the data collected there's been an error in the way we collect data, so that's gone back to the digital team to actually work out, so we've got a true reflection. For 3rd and 4th degree tears, it's important just to recognise that actually we are in common cause for concern within the trust, but actually nationally we sit well within the variance. It's just that we've seen a spike, and that's what's concerning. So we're just getting to the bottom of that, and it is only in one particular area. So it's actually only for women who have had instrumental births where we've seen that rise. So Shanta is doing a piece of work around that, so hopefully in the next couple of months we'll see some improvements with that. And the other item is internal deflections. And again, we've seen a drastic reduction in internal deflections since we've reopened Helm Chase and we've introduced the Cross Bay working midwifery model of cover. So that's come down quite nicely and is actually almost there.
That's great. Thanks, Susan.
Karen.
Oh, thank you. And thank you, Susan. It's I just wanted to refer back to the inequalities lens within the dashboard, and it's really great to see that now. So thank you for that. I'm just wondering really whether the plan is to develop that inequality, that population health lens further, so that we can actually see that lens into other metrics that we see within the dashboard. Is that something that's planned, and how would that inform the improvement programmes through that population health lens?
I think that it's a really good question, Karen, and it's in my heart to have a look at how we improve maternity care for those women who are most disadvantaged and for those women who are hardest to reach from a maternity care perspective. So absolutely, one of the things that we're looking at the moment is developing continuity of care models, and particularly enhanced continuity for those women who have more risk factors, who come from a lower socioeconomic group, those women who come from Black and ethnic minority groups. And actually, if you look at the data at the moment, it's Asian women who seem to be occupying the statistics with regards to morbidity and mortality, which is concerning. So I think, in our planning, it's important to actually examine what demographics we have in our local population and then adopt those approaches to meet those particular needs. So we're not just doing a blanket approach, we need to do targeted approach to where we've got the concerns. So we'll be looking at that as we look at our models of care. So thank you.
No, thanks. I really look forward to see that
Yes,
developing.
it's exciting.
Thank you. Yeah, thank you.
Tabitha.
Just for assurance, Chair, for assurance for the board and Aaron's question in terms of seeing the data from maternity, we now have it brought into our governance processes. So we now can see these 4 areas through performance and assurance combined within the division. So, which is strong.
Great. Good. Are there any more questions on this item? If not, we'll move to item 29, the Integrated Performance Dashboard for Assurance. Can I ask Scott to introduce this?
Thank you. So the usual format, we'll go through the 4 domains, starting with safety and quality.
Thank you, Scott. So just to sort of say, these have also been through the IPR. So in terms of our patient safety incidents, we did see a kind of dip in terms of reporting, but that is improving. So we're seeing common cause variation and we remain below the median, which is really good. We've had 2 incidents that have gone through the Strategic Executive Information System, which is STIS, through to our ICB. In terms of our PSEF reporting, the current position is that we have 27 PSIIs, and we now have all our PSIIs allocated. So there is quite an improvement and we should see the numbers reducing. And those that have been like out of time, for example, have been waiting for like over 6 months, they should be picked up and we should see an improvement trajectory around our PSIIs and learning. The most important thing from that is about one of the feedback that we have heard that we will bring our learning responses and the themes as part of the stories and feedback to board. Around our complaints, I'm happy to sort of report and say we've got no complaints exceeding 5 months, 0 complaints requiring revisits. This is a good place to be. However, we have had 1 or 2 that have gone into the 5 months, but they'll be reported next time simply because of either delays, because people were supposed to sign off our annual leave or something. So we keep monitoring that, and our aim is to keep to our trajectory to reduce the time that, waiting to respond to people, because we also learn from the complaints. Duty of conduct in April, there were 39 duty of conduct commissioned that were completed within the 10 working days, which is the requirement, and 2 were slightly over. Total compliance is good, sits at 94.8%. In terms of our falls, 101 inpatient trips, slips and falls, 1 resulted in moderate harm. I'm going to go through this because I just want people to really understand in terms of the number may look high, but it is about where we have actually caused harm. So within those 101, 1 resulted in moderate harm and there were no lapses in care identified. 74 falls resulted in no injuries at all. 50 out of the 101 had clinical frailty score of 4, which means they were vulnerable or more. And 23 patients fell more than once. And 24 patients were in the not meeting criteria to reside at the time of falling. And we're doing a piece of work to look at our numbers within the not meeting criteria to reside and triangulate with incidents to see whether and the report will be going to QAC. So overall numbers of falls, 8 data points demonstrating very good improvement. I just wanted to mention that. And then pressure ulcers, we've had 32 category 2, 3 category 3s, and we have, for as long as I've been here, had 0 category 4, which sort of fall into a safeguarding concern. Friends and family tests, so as was alluded by Annette, the numbers are there. I'll wait if anybody has got any questions to ask. In terms of mixed sex accommodation, this will continue to happen where we've got 18 breaches related to delays when we are transferring from ICU into the general wards because of the limited side rooms within ICU. IVC, we've had 5 cases of CDI, 14 cases of GNBSI, which is blood-borne disease, 1 case of MSSA, and 0 cases of MRSA, which is a good picture. And when we triangulate nationally, we are not an outlier on any of these. And we have got deep dives into, for example, the 14 cases of GNBSI. There is work that's being done by the teams to look at our catheter use and all that. So all of the above were healthcare associated. And I'll hand over to our interim medical director.
Quite a few acronyms in there, so just to say the words, not the acronyms. Sorry.
Okay.
Thank you.
So BTE, the last time we reported, we were at 67.8%. We are now currently on 71% of the live data up to date. There's a few reasons for that. So the UHM BT Breakthrough Collaborative Series started on the 1st of May, which had lots of different actions, including champions, including making sure we had a BT lead, which is now in post and has been for a month. We've got junior doctors going around the wards as part of their development, targeting individuals in areas where the uptake isn't so good in terms of our assessment figures. And this is all starting to work. We're getting out on team talks and all the forums, audit committees, DCMO, like that. So it's been, the divisions are really owning this bit of work. And in the last couple of weeks, our surgical and families division has gone from 56% to 62.2% today. And the MEX division has gone from 73% to 79.8%, which is what's given us our data of 71% overall. Some of the issues that we have bottomed out as part of this work is that we've had an issue with Lorenzo dropping some of the data. So we haven't fixed that. We now have mitigations, so we are reporting the right stuff. And the other problem was a mismatch between what medics thought we should be reporting on, because GERT recommendations and NICE recommendations are different. So we have now bottomed that out. So they all know that we are reporting to the NICE, which will make a huge difference in terms of our D cases, which should bring up obviously the surgical and Westmoreland in particular percentages. So that has only really just started in the last couple of weeks in terms of change of form on Lorenzo. So we should still see continuous improvement there. And we've also managed now to get the data of the worst performing medics in terms of who's not doing what they're doing, and that has to be very carefully individually. So an improvement by 3% on last time we reported. Shimmy wise, so we were flagging for fractured lymphedema, that's now gone green on the live dashboard, so we are no longer on it for that, and that is due to again a number of deep dives in terms of why that was a problem. Some of it was coding issues in terms of we were just taking the wrong people out, so pathways, and we're taking the wrong people to theatre, or we were coding them wrong, as in we were coding them as coming to harm, but actually they were palliative patients and we were doing the operation for palliative reasons, that just wasn't being picked up, and that's a different set of data. So we've bottomed that out, and now we have very robust autogeny cover, which we have now had for the last 2 months, which has helped significantly. So we are now green on fracture lymphedema. We are alerting now on COPD and bronchiectasis. The reason for that being is coding. So we have deep dived all the patients that we know have alerted to the mortality team, looked through every one of them individually in the notes, and we are confident 60% that we have now gone through to date that none of them have come to harm, and it is just coding problem and not a harm issue.
Very good. Right, takes us to the next section, which is somebody else.
Me, Scott.
I've got the blue pen.
Just the English transition.
Really slick there.
Started about 3 seconds before. Thanks, Ali.
Just before I pick up the people element, I think it's probably relevant for board to be aware in terms of the coding issues. So we have started a task and finish group. So the issue that we have with this is that the volume of coding that's required to be done cannot be met by the resource that we have in the organisation. So we've set a task and finish group up with a clearly defined remit to report back through the investment priority group and into the executive team by the end of July, so that we can make some informed decisions in terms of next steps in relation to addressing that particular issue. So if I just move on to the people section. So we had reported previously that we would anticipated that the budgets for the staff who had transferred to One LSC would be moving to enable us to have accurate workforce reporting from 25-26. That hasn't yet happened. We're not expecting that to happen probably until month 4. So it will be July data before we stop and you stop hearing from me around the reminder that this is being skewed by the One LSC transfer. So vacancy data technically is in special cause variation for concern, but it isn't actually a special cause variation cause for concern when you extract the elements that are associated with the transfer with One LSC. So we have got an increase in vacancy rate. We anticipated this because we've been holding particularly some of our nursing and admin vacancies associated with supporting potential future redeployment requirements aligned to the transformation plans and the waste reduction plans. So we are trying, if you triangulate that with the turnover, which remains absolutely stable, that gives you that indication that the vacancy rate isn't in a statistically significant way varying. It is still stable in respect of that triangulation with turnover. And again, from a quality and safety perspective, if we again triangulate with the registered nurse fill rates, they still remain in common cause variation. And we've been making additional use of bank to ensure that where there is a requirement from a safe staffing perspective, that those shifts are being filled and those decisions are being made on a shift by shift basis. In terms of sickness absence, you can see that whilst we're still in common cause variation, we have decreases in our sickness absence month on month for several months now. Occupational health and wellbeing service demand continues to increase though, and we have got a real balance in with managing the reactive referrals and the proactive health promotion, health screening and surveillance activities. The performance data for occupational health, the key performance indicators remains very strong with one exception, that has been around the access to the occupational health physician. That is now improving because of some workforce skill mix changes that we've put into place, particularly around some use of advanced clinical practitioners in occupational health that are meaning that we're only putting the work to the physician that only the physician is able to do. So we have seen some pathway and workforce reconfigurations in there that are improving that the key performance indicator now. And important for us to recognise that our sickness rates at Morecambe Bay remain significantly lower than all the other trusts in Lancashire and South Cumbria, and for the majority across the region as well. The personal and professional development core skills completion does remain in common cause variation, and appraisals now are being managed and monitored through the divisional performance reviews through clear trajectories for improvement that we're going to, and measurable ones that we're going to be managing through the performance review process. And just so colleagues are aware, because it'll link into what Helen's going to say in a second around agency and bank usage. So there is the letter that was received from the Secretary of State and Jim Mackey is the Chief Executive of NHS England, with 2 key actions. So there has been a review of the medical bank rates against the equivalent pay received for an equivalent agency worker. That does have some implications for us that we're needing to work through. So that's been analysed, and we'll be pulling that through in the first instance through Pay Control Group to ensure that the risks in relation to service delivery as offset against the potential financial benefits of that are fully considered before we make any changes in that respect. And the other action from that was an exploration of the use of NHS professionals for organisations who don't currently use them for their bank and agency provision. We're taking a system-wide approach to this, and a meeting took place last week. There's some analysis now being completed, and we'll take some detailed analysis and recommendations through to the Provider Collaborative Board Executive Committee later in July.
We are actually sat in order. Thank you. Can I just note on the agenda, it actually says the IPR for month 1 and it should be for month 2. Just correction there, thank you. So month 2 in financial terms, we were £500,000 away from our plan. That had deteriorated slightly since month 1, but we, to all intents and purposes, had delivered a significant element of our waste reduction requirements for months 1 and 2, which is very positive. Having said that, we've clearly got some deficits within our income and expenditure position. Our income is slightly behind plan in diagnostic imaging, community diagnostic centre, and in some of the day case and elective case mix, i.e. some of the cases that we planned to do were not necessarily the ones that were actually achieved through our activity. So we are looking at where that is and why and how that can be recovered. We do have an underperformance in our waste reduction programme. It is offset by some continued good performance in our underlying run rates, and divisions are challenged to assess whether or not these are permanent reductions, and if so, should we actually be reporting them as part of our waste reduction programme. I do think there is some correlation there and some validation still to conclude. We are supporting the position with some non-recurrent mitigation, which clearly is only supporting the slippage in the programme and gives us that time to ensure that we implement the requirements as we move through the rest of the financial year. Quarter 1 is really significant for us in terms of our financial undertakings, and we have a requirement to improve our underlying rate position quarter on quarter. We were in a discussion yesterday, and our regional team are going to provide some narrative around how we calculate that. I'm sure that will be a complexity in itself. Our run rates do continue to improve. We can definitely see the results of our actions around the control room and our non-pay controls being borne out there. Ali's already mentioned the agency position. Our cap this year is 1.9%, and at the end of May we're at 1.23%, which is an excellent position to be in, as long as we are covering the vacancies that Ali talked about. I was very lucky earlier this month to go to London to meet the new Chief Finance Officer of the NHS, which actually ended up being really good interview preparation for me. I'm now sat here as the Chief Finance Officer. The clear message there was that cash is the national priority, the absolute priority. We don't talk as much about cash as we probably should do. We're going to change that. So we will be developing through the Finance Committee an enhanced cash reporting mechanism, And I think this will be in advance of us receiving additional cash requirements through new financial frameworks. We will also be developing a slightly different risk matrix for the Finance Committee and the board to be aware of as. We also need to be aware that our system only receives cash support, deficit support, if all of the organisations meet their objectives. So we need to obviously participate in that. We were clearly lucky as an organisation to finally receive the local price modification of 22.5 million that Aaron set the charge on a few years ago. That's clearly supported our cash position by 1.9 million a month. As such, we're in a much better position than we were at the end of last financial year. But we need to ensure that that is maintained. Our pay bill is about 30 million, so it's soon eats balancing. So we'll just be focusing a little bit more on cash as we move into the next quarter. Thank you.
Okay. So for me then, the operational access and performance, start with urgent and emergency care. You see in the pack for the April data that 4-hour access was performing at 74.5%, and that's lower than we would have liked, than lower than we planned. We have since that date seen 7 consecutive weeks of improvement, which is very welcome, including last week where we saw another week of improvement, and therefore on Sunday finished June at 76% 4-hour access, which is much better. That's we've seen that go up to 79% at Furness, 61% at RLI. KUTC having dropped off slightly. That's obviously 2% short of the 78% national target, but I think gives us a better confidence, having seen 7 consecutive weeks of improvement, that the things that the teams are doing are indeed being impactful. Another day, and probably certainly not straight to public, we'll take some thoughts around the Kendal Urgent Treatment Centre. Caroline, Tabitha and I are in a conversation with the Medicine and Nurse Care and Children's Division around KUTC, where the attendances continue to rise, the acuity continues to rise, and there may be a point where the staffing model we have there is not one that we can perpetuate. So we'll come back on another day around the long-term thinking around KUTC. You see that we're still benchmark positively in urgent care, but actually the benchmark, while reassuring, doesn't speak to the fact that we know we can be better, and certainly getting to 85% in Furness and 65% in RLI, we know gives us a composite trust performance of 78%, and that's the very minimum that we'll be seeking over the rest of the summer. 12-hour, as ever, 12-hour and ambulance handover performance are a function of the above, so nothing specific to draw out in those. Not meeting criteria to reside, you will see, remains in common cause variation at around 25% in the reporting month. What's not in the graph is the distinction between sites, where actually that's neither 20% at RLI, but over 30% at FGH. Cancer, you see we're less than 1% below the target, so keen not to spuddle, given that we're still in common cause variation, and the denominator is small for 28 days. It continues to be in special cause improvement for 31 days and 62 days, just shy of the 70% target, but I've got no concerns there. I do have a mild concern that by a mile, the greatest number of breaches are in urology, and we know that we've got wicked issues of capacity versus demand gap in urology, and trying to balance those urgents and cancers is difficult, and current theatre timetabling doesn't lend itself to that. So there is some bespoke work we're doing in urology, and we talked about that in performance review last week to try and address that. Diagnostics, you'd be right to be concerned about the graph on page 212. Things have moved on, thankfully, since that graph, and we have now got fewer than 40 patients as a backlog for DEXA scanning, as opposed to many hundreds of other case when this graph was drawn. So we'll see that back on track in this calendar month. Non-obstetric ultrasound then is the other biggest driver. We will see that back on track by around 7 or 8 weeks' time, by the end of August. And certainly by the first week of September, we'll be looking for that to be less than 5%. What we'll then do is take on the more kind of medium to long-term workforce planning to avoid us getting to this place again, given the fragility of that sonography workforce. Referral to treatment times we'll cover in detail in a later paper. But you see here, as we know, as we predicted, we would move from a long period of special cause improvement in 18-week referral to treatment times to a Q4 period of common cause variation at 68%. I think it's troughed, and now it's reached its trough of around 67.8%. And I'm hopeful that what we're doing will see that come back up to our resourced plan of 70.1% 18-week RTT. We'll talk later around the difference between that and the 75.1% target. 65 weeks, I'm not concerned about. 52 weeks, we will seek to go up. A question you may ask, and I'll take through F&P committee at the appropriate time, is on that graph on page 215, where you've seen 4 data points of deterioration in 52 weeks. Where does it peak? I'm not sure I can answer that immediately, so we will take a piece of work on that through F&P, because we know, given the morphology of the waiting list changing this year, where the focus is not as much on long wait, it's more on 18 weeks, that will shift the number of patients waiting around 52 weeks. So we'll take some detail and try and explain that as simply as we can through F&P. Otherwise, the only other thing I wanted to raise was you'll see our missed appointment rates, which, although in common cause and variation, are certainly for the last 5 data points hovering around our target of 6.5%. What's not to be lost, of course, is that the missed appointment rates for patients in the core 20+ population is about 50% higher than that. So it runs at around 10 to 10.5% for that population, and we're doing some work in there, but we'd like to do some more. Very final point is around page 221 in the pack. At face value, you would look at that and feel slightly horrified. I mean, you see E's and D's in a stroke snap table, and you'd be right to. The reassurance we've given through the quality committee is that very helpfully it gives the crude score there, and we know that the crude scores have been maintained, or indeed even slightly improved, since the old SNAP scoring metrics changed to the new, i.e. in old money. If you look at the very top row, that score of 50 or 62 in Q3 and Q4 was still 50 and 62 a year ago, and would have generated an A or a B. So the numerator has stayed the same. We're assured that there's no deterioration in the quality of care. This is a function of the new scoring matrix. What we'll do, now we've got these data, is we'll present that in a way that's easier to assurance from, both through F&P and board. That was all I had, and I think that concludes the IPR. Let's take any questions, Chair.
Patrick, thank you. Scott, thank you. Oh, there's that with Sarah.
Thank you. I don't have a specific question actually, but I think as a chair of Quality Assurance Committee, we normally just respond, I think, on the relevant section. So to confirm, obviously we did review this at Quality Assurance Committee, and there were just a couple of points I wanted to pull out. So Tabitha touched on the PSII, so patient safety incident investigations, and as well as that being included in the Quality Committee IPR, we also received a paper on piece of Quality Assurance Committee committee. And so I just wanted to update on that, just to add to what Tabitha said. So obviously, I think we're reassured by progress in implementing PSERF. We know that there have been a number of different business cases for how it should be resourced, and that new model is not yet in place. So we still can't be assured about the implementation model, but we're reassured by the recovery plan that Tabitha highlighted. So I just wanted to acknowledge that for the PSERF. And then on venous thromboembolism risk assessment, I actually first wanted to acknowledge actually, Cass, because your sharing of that report and board clarified a couple of additional points for me, which was really helpful. So Quality Assurance Committee has been frustrated with progress in addressing this trajectory. And about a year ago, we started to feel much more assured by the quality of the data that so that we understood much better what the gap was between where we needed to be and where we were. And the update you provided today has about like clinical engagement and actually clinicians. I know you provided this at Quality Committee, by the way, it's just it landed differently today. That actually, for me, it highlights the importance of the clinical engagement. So we knew organisationally, we knew what the data gap was, but actually the clinicians didn't understand that, what they needed to do differently. And so I think I just wanted to acknowledge the improvement programme that's in place and the impact that's already starting to show. Committee continues to look for assurance against that trajectory, because we are still behind where we needed to be at this point for that trajectory. So I hope that makes sense, but I thought it was helpful to add some things.
Tony.
Yes, this report was also received at the Finance Performance Committee, which I chaired for AMIN, and we did go through it with a lot of consideration and reflection and sought assurance. If it's okay, Chair, I'll reserve comments in regards to the Waste Reduction Improvement Programme and criteria to reside in my 3A's report. Just two comments. One is a real positive thing that was in Helen's commentary. When you think the journey of this trust has been, and I'm talking about finance for a minute, right? From 80 million deficit to 38, to potentially working towards a balanced stroke small surplus. I have to say that's cracking in terms of the corporate team. And I also want to say, and put on record, thanks to the Chief Executive, because in that context, to get price modification to the tune of 1.9 billion a month coming in is just it's stellar. It's first class, and I think that's no small achievement, because we know what the processes can be like and the accountability arrangements. But I think that's credit where credit's due to Aaron and the team for doing that. The second is a question which might be a bit difficult in the context of our overall performance and also the wider regulatory piece. In the new performance assessment framework, where the new arrangements going for, where would we sit in that new world, or is that too difficult to say?
Yeah, and talk about that this afternoon.
Okay,
we've had some notifications just to talk through, but yeah, we just need to give it some consideration.
Okay, thank you. So that.
Karen.
Oh, thank you. Yes, just to confirm as chair of People Committee that the report from Ali today absolutely resonates with the discussion and the scrutiny that we undertook at People Committee, and that will be reflected later in the 3A's report. And then just a question, if I may, about stroke and the shift from the SNAP data. Scott, I absolutely understand the explanation about the numbers being consistent, but the rating changed in light of the new kind of national standards on that. And it's just really a question about how confident we are that we're going to be able to respond to what seems to be a raised bar on stroke services. What's our kind of confidence on our ability to deliver against that new set of metrics?
Scott.
Thanks, Karen. Yeah, so the approach we've taken is to stabilise and then start to take a view on what it would take to get to a new level of A and B. So now we've got these data and we've made the transition. I'm comfortable that we've largely stabilised now. We understand and we can see it. So what we're asking the teams to do next, both in the MEX and the CCDE division, is to do that gap analysis that says to take those scores there of C's, D's and E's and make them A's and B's. What would that take, and indeed what would it cost? And I guess then there'll be a decision for us around, are we content with the level of safety, quality, outcomes, performance, or indeed, if not, then where would we want to take a risk-based approach to invest in what it would take to get to those standards? So we'd hope to do that certainly in Q2, to do that gap analysis and lay out what it would take, and as a function of that, what it would cost.
Okay, thank you. That's really helpful.
Any further questions? If not, let's move on to the second part, which is minutes and the 3A reports from the assurance committees. We'll be starting with the audit committee. So, Nicola. And if Nicola is unable to speak to this, I'm going to turn to Tony.
Shall I make a start, Chair?
Yes.
Yes, so you've got two reports. I'll use the 25th of June report because that's the most current and recent. Busy time of year, as members of the board will know. So at the previous committee on the 25th of June, the following were approved: the annual governance statement 24-25, the annual report 24-25, the annual accounts 24-25, and the letter of representation. We also noted the auditor's annual report 24-25, which I'll come back to. I have to say it was a well-run process. It shows, as in the content of the reports, that processes and protocols in line with trust policy, the objectives of the NHS, etc., that they are providing us assurance that we're running an organisation that is fit for purpose and in line with the licensing. In regards to the auditor's annual report, the only significant concern raised was in regard to the issues of financial sustainability, which, let's be honest, we know about. There's a lot of debate, as I've just said in my earlier comments in regards to the previous item. We've got a good track record, but I think on balance, it's probably a fair summary. At this time next year, it will look, I suspect, a different kind of set of words and descriptions. We also had the final head of internal audit opinion, again, which provided substantial assurance, good system of internal controls designed to meet the trust objectives. I also want to put record thanks to the chair and the team, because it was noted that in the context of all that's going on, all the returns, all the required pieces of process were done and delivered on time. And when you think of the context of what's going on, that's no small feat. So I think I'll leave it there, Chair, if that's okay.
Thank you, Tony, for stepping in for Nicola for that item. Any questions, Tony? You good? People committee. Sorry.
Can I just raise a point of clarification to support Tony's report? The element that you described around the lack of assurance about financial sustainability was part of the auditor's value for money assessment. So that's just the context for that element, and that had not changed that specific area since last year. The other two areas within that rating actually improved from amber to green. So I think I had quite a debate with the auditors about that. But actually, you know, as I think the board would recognise, we appreciate that our financial sustainability appears to be requiring improvement at that level. So that's just a point.
Thank you, Helen. Can I just ask the board to approve the 3 recommendations from the audit committee? I'm happy with that. Yep. So then moving on to the People Committee minutes, Karen.
Thank you. Before I just give the 3A's report, Nicola has just asked if we could formally record her apologies from this point onwards, please. She's got some urgent concerns she needs to respond to. So if we can formally record those, that would be great. So just going on to the People Committee 3A's from the meeting on the 23rd of June. Just 2 points to alert the board to. The committee was particularly concerned about the proposed transfer of the occupational health service to One LSC that was proposed to take place from October. We've heard earlier from Ali about the exceptionally positive service that occupational health have been delivering under pressure. And in that context, we were particularly concerned about the lack of clinical leadership and experience of managing occupational health services in One LSC. And we very much asked for that to be reconsidered. Absolutely, as a committee, supported retaining the focus on a system-wide service model, but questioned just the current position. Essentially, the rationale was we wouldn't be considering transfer of any other clinical patient-focused service at this time, and essentially that's what the occupational health service is for our staff. And then the second alert was in respect of the One LSC transformation plans. We were really seeking assurance that no changes to structures or operating models will be enacted before they've been considered and endorsed by the relevant professional group, so that we can be absolutely assured about safe and effective service delivery. So 2 key alerts. In terms of advice points, one of those is a referral onto the private board of directors. So we'll discuss this afternoon about the governance assurance arrangements for LSC, and that very much mirrors an action from the Finance and Performance Committee there. So very much like-minded with the other committee. And then just a couple of points to pull out other than taking the report as read. We did acknowledge the increased demand on our trade union representative colleagues just in terms of workforce capacity. We acknowledge that, and we'll just continue to keep that under review. And with regard to the DBS checks work programme, board will be aware we were expecting that to be a final report at this time, but some of the administrative pressures on completion of some of the actions on that have caused a delay, and we are taking a final report that will be a hard stop point in this work programme in October. Just for assurance, to report, we were as a committee assured of the design, approach and resourcing of the organisational change and people support programmes. So we were assured of the approach and resourcing. What we're really looking now is for evidence and assurance around uptake. And we noted that will be addressed through the divisional performance review meetings. And we were particularly positive response in committee about the growing consistency and ownership of actions through the divisional performance accountability reviews, particularly the clearer improvement trajectories that we're seeing coming through there. I'll stop there.
Thank you, Karen.
Yeah, thank you, Jay. Thanks, Karen. Just on the One LSC 3 alerts from the Assurance Committee, I think we need to revisit, we'll do that later on this afternoon, the governance and oversight arrangements for One LSC and where the risk oversight sits. I think is a gap at the moment because we don't have the information here as an Assurance Committee for UHMBT to form a view. I have asked Ali as the exec lead to work with the system on 2 pieces really. One, I call it dovetailing of client side oversight, assurance, service specification oversight, etc. within trusts, so we can have an engaged conversation with the One LSE leadership team. I'll pick that up as an action to work with the system on for us. The other element is making sure that we've got a good understanding of the transformation programs, particularly from the value that we put in One LSE for our WFRP and how we maintain that oversight of service delivery. So I know we'll talk about it this afternoon separately, but I wanted to track at public board a couple of things around governance and assurance. It's with the Joint Committee and the CSES, that's the delegated autonomy. We just need to make sure that we've got the right information and the right dovetailing within our assurance structures to form those views, and it'll help engage back with the system assurance structure, which I've asked Ali to read.
Yeah. Thank you. That's really helpful clarification. Thank you.
Any further points on this one? If not, can I turn to Tony, the Finance Performance Committee?
Thank you, Chair. So in Amin's absence, I chaired the committee on his behalf. So just briefly, two reports, but I'll keep to the most recent one. First of all, we supported a request for a 3-year extension to the Lorenzo contract business case. It's a fundamental clinical quality tool that we need, and therefore we supported the proposals of the business case, and we were assured that it had gone through procurement, proper procedural processes. Secondly, we focus on the finance touched upon earlier in terms of the waste reduction improvement programme, financial improvement programme. To cut to the chase, I think we've done incredibly well to identify the 32 million, circa 32 million. I think the next piece that we identified was the profiling, what, when and how, what were the risk mitigations behind some of this, and also the capacity and resources to do that. So there's some further work to come back for further assurance at the next committee. We had further conversation and discussion about no criteria to resign. Got some assurance in regards to the progression, but again, we identified 3 elements. We wanted to understand more where the percentage of patients not meeting criteria to reside within the trust's control, what those numbers were, because obviously there are things beyond our control, but it's about demonstrating the benefits of what we're doing. That's probably didn't quite come out. There's a read across to the waste reduction in terms of the clinical financial impact of this, in terms of safety, provider care, but also in terms of the waste reduction improvement programs. So we just want to kind of keep a close focus on that. We had a conversation, thirdly, similarly about One LSE, so I won't repeat all that because it's been picked up, and we said we would appreciate a paper coming back to the 2nd July meeting, which we have today in private part. And finally, we discussed the BAF again, quite appropriately. So we talked about the waste reduction trajectory as potential new inclusions, not meeting criteria to reside, One LSE oversight and governance arrangements, and the cash flow risk, which links into the conversation in your feedback under the board report around finance performance.
Just recognising the escalation around NMC to what we've agreed an executive action, which is I'll be meeting with Tabitha, Louise, Bong, and a couple of other colleagues with the revised trajectory and the risk-based approach to what we do around cost release, particularly with the WFRP. We'll be doing that on my return. We commence in the 14th. Thank you.
Great. Any other points? If not, Quality Committee, Sarah.
Thank you. So I'll just start by making it a house on concerns that we wish to escalate relating to assurance and potential impact of implementation of One LSE and cost savings. We saw 2 sets of information at Quality Assurance Committee which raised a concern. One was in the a couple of the committees that report to Quality Assurance Committee, so health and safety and infection prevention. Both of those contained an alert relating to impact on staffing of state facilities on areas in those committees or in those assurance groups. So that was the first area, and the second point was we received the annual place survey statement for the trust, which relates to the environment of patient care, and the colleagues will explain better what the purpose of that survey is. But there was an area within there which relates to privacy, dignity and well-being, which does directly relate to quality and safety and patient experience. And we didn't see any mitigating actions highlighted in the report, so we're not assured by the response that's being taken, and so we don't have the route to seek that assurance because it's not all given. So again, it's related to that escalation around how we can receive assurance on those things. So going back to the 3A's report, it is a bumper 3A's report which reflects the bumper agenda that we had at Quality Assurance Committee and the bumper pack of papers that we received from Quality Assurance Committee, which was quite an ask for all of the committee members. And actually Paul Jones has taken an action to review the process for those papers to ensure that we can actually get through all of the business we need to and the volume of papers to make sure we can do that in an assured way. So just moving back to the 3A's report then that you have in your packs, I do want to raise that we've alerted around the impact of the coding delays, which are now starting to show for quality and safety. So Ali, thank you very much for the update. That was also discussed at Quality Assurance Committee, and Kaz has already outlined the couple of areas that's particularly having an impact on around mortality, and also something around specifically fractured neck has been reported as well. So we reassured that task and finish group's been set up, and we did request an update for this to come to the next meeting of the committee in August, because of the fact that it's impacting quality and safety. So that's the first point to alert. We received the first of the new style of risk management reporting. I won't go through all of the things that are then highlighted in the 3A's report, but the two things I wanted to pull out were that we did note the risk related to pathology, given that this has been an area of concern and focus for the trust in the past. We felt it was important that as a committee we receive an update on that to start to provide some assurance. The second area we noted was the phlebotomy service. We know that that's fragile staffing area that people committee is also monitoring, but we do want to ensure that the quality and safety aspects of that are monitored through the committee, through quality. So both of those have been requested for the next meeting of the Quality Assurance Committee. We are just working through, we recommend the new risk management strategy to the board for approval. I know it also is considered or will be considered by audit committee, but we received that at Quality Assurance Committee. Other points to mention, apologies, I've got quite a lot of this. We did receive an update on Martha's Rule. You'll recall that the first phase of this came in around a year ago, and our trust wasn't in the first phase, but is in phase 2, and it's been in the national media again recently, I think partly because of moving through that. So we received an update of Quality Assurance Committee that we're now starting to put a detailed plan in place, which is led by Lynn Ryan, and the detailed plan will come to Quality Assurance Committee in August for consideration. We also received the full response that was submitted to the coroner in response to the inquest which concluded in March, and a finalised action plan, which will also include the ICB's response, will be coming to Quality Assurance Committee in August, so that then Quality Assurance Committee can monitor and receive assurance on the impact of that. We did query one of the areas which we highlighted in Coleman's report around the fragility of clinical governance staffing, and we received an update on where that is currently and where we hope that expect it to be in the early autumn. So we will be assured by that. Just want to check if there's anything else. I think those are the key things that I wanted to pull out. So apologies, that was a little bit long, but we covered a lot of ground in the Quality Assurance Committee. Thank you.
Ashley, I can vouch for that, having attended the meeting. Any questions, any points of clarification on that, Tabitha?
Yeah, thank you very much, Sarah, because you asked about place and what it means, and you said maybe some is what it's about led assurance visits for clinical environment just to check infection. So it's patient-led.
Great. Well, if there are no further points on that, we'll move on to item 30 on the agenda to consider a report on the revised elective activity plan 25-26. Scott.
Thank you. So as it says on page 337, this went to the Finance and Performance Committee on the 19th of May. And the committee agreed with the approach. And we noted that a further update would come to a board of directors meeting, which is what this is. So in short, we submitted as part of our original plan where we're examined against does the activity, workforce and finance plan triangulate. We submitted a plan which was congruent with our outturn performance of 70.1% for 18-week deferred to treatment times. And that, important to note, that baseline was taken in November 2024. Two things then changed. Firstly, as we know, we changed the way we deployed resources in quarter 4. So our outturn position for 18-week deferred to treatment time on the 30th of March was no longer 70.1%, it was near 68%. The second thing that changed was we had feedback from NHS England colleagues to say that our activity part of our plan wasn't congruent with national guidance, which was that trusts, all trusts must make a 5% improvement in RTT, or if you are already at 65%, sorry, that's not true. Start again. All trusts must reach 65% 18-week RTT as a minimum. And if you're already at 65%, you must make a 5% improvement. So for us, that would have meant not 70.1%, but rather 75.1%. So we submitted a plan that described the numbers we would need to treat every month to achieve that. And sent a cover letter to that to say that at this point, that wasn't a plan that was resourced and it wasn't congruent with our original activity and our initial workforce and finance numbers. We've had lots of discussions since with both the regional team and the ICB, who have been particularly supportive of the position we're in. Important to note that even at 68% on last week's data, if you exclude the specialist trusts, we were the second best performing out of 19 trusts in the northwest of England for elective access. But nonetheless, we've got the arithmetic's clear. We've got an ask to achieve 75%. So we are speaking to the ICB weekly. We believe that there may be a chance that we, as I've said in the paper, getting to 70% is quite a stretch. Getting to 70% is a de facto 4 to 5% productivity ask for us, which is very, very big. But even within that, we think from some of the work we're doing, we may be able to eat 1.5 to 2% into the 5% gap. But without additionality, then it's unlikely we'll achieve the 75%. And so those discussions will continue. It's at board to acknowledge all of the above, I guess, but there is a gap that is as yet is not resourced and doesn't have a plan, but that we're working on it. So the ask is to note that we've submitted the 75.1% as requested, to note that at this point it doesn't add the finance and workforce, but to note that we're working on it. We'll make some marginal gains, we hope, above 70.1, and we'll continue to seek the resourcing we think we require to get to the 75.1%.
Thank you, Scott. Any questions? Okay.
So a really complex kind of set of actions that we need to follow here, given the direction we have around what constituted a compliance plan within the guidance. So Scott and I have met a couple of times over the last month or so, including with Region and ICB, on what we think additionality might look like. So I think there are two clear actions we take here. One is under the improvement kind of work that we're doing internally through Finance Committee into board. How soon do we put forward our trajectory of what we think our best offer is within our own team? So the 1 to 2% we think we might need to progress, I'll ask Scott and the team to start to build that into our forecasting for oversight in terms of elective recovery trajectories for this year. The latter point around additionality, I think we need to lock down by the time we get to the end of August, heading into Q2, which is probably 6 or 7 weeks in reality, is to secure whatever we believe is available from region or ICB for additionality of investment, at which point I would suggest we come back to the board to lock in what we think our latter 6 month trajectory is, both from an additional investment perspective and our own internal improvement perspective. In the meantime, I know the teams are working hard to get to that 70.1 and beyond, but I think we just need to lock in a bit of a timescale and a couple of process actions there to bring back to board.
Tony.
Yeah, totally support what Scott and Aaron just said. What's the experience for other trusts, not just within the region, because there must be other trusts in similar, I mean, others have got bigger gains to make, improvements, which must have similar implications in terms of finance and productivity. So it's just what that comparative, or is that too difficult to say?
So I can't speak for other trusts, only
Right.
what I can see in submissions. So I don't know what's got underneath it, what contracts they've secured, what the.
So there's no kind of sharing of intelligence or dialogues about this in terms of the systems?
Not at that level, Tony. No, I think locally, each trust has submitted a compliant plan. Being candid, lots of trusts around us in this system had more to do, but had plenty of scope and opportunity. We've been pushing on high productivity and efficiency for a long time.
Right.
So it's, I don't want to say it's easy, but the opportunity is easier to access for their improvement than it is for us. But yeah, there isn't a comparator of the type that would answer that question.
Thank you.
Any further points on the revised elective activity plan? If not, can I thank you all for your incredible brevity that we are perfectly on time for a brief 10-minute break, a comfort break for everyone. We will restart the meeting at 11:05 exactly. I will see you all again shortly. Thank you.
Heather.